Welcome this afternoon to St Aloysius in Garnet Hill in the centre of Glasgow. My name is Father Gerard Mitchell and I am the parish priest here. And recently our community has been having a series of meetings about palliative care and care of the terminally ill. So it's lovely for us that you should be with us this afternoon, Gillian, to share with us your experience of palliative care and your passion for palliative care. So it's lovely to welcome Dr. Gillian Wright with us this afternoon. So would you like to begin by sharing with us your thoughts and your passion for this great service?
Thank you so much, Father. It's a real privilege to be here and thank you for having me. Thank you. My background was in general hospital medicine in Glasgow, and then I changed to work in palliative care, and it's a real privilege to work amongst those who are terminally ill. I worked with those who were unwell in hospitals, but also in hospices and acute palliative care units, and in the community. And palliative care is, in some ways, it's a way of looking after people, and it usually involves quite a big team. So there are doctors, there are nurses, there are physiotherapists, occupational therapists, psychologists, but also volunteers. There are folk who come in and sit with people, who do the flowers and make a whole community around those who are particularly unwell with a life-limiting disease or who are dying. And it is also delivered by those who are GPs and by district nurses in the community, perhaps in care homes. And so I was really glad to work in that environment. And I think, although sometimes people say to me that must have been quite a sad job, actually it was remarkably positive, because there was so much that you could do to make people's lives more comfortable, both from their physical symptoms, but also from their psychological distress. Because most of us are anxious or distressed or concerned when we face death. And part of our job was to be with people as they thought about that and adjusted to it. And some needed extra special time and resources, and that's particularly what a hospice would do. There's also often social workers involved and chaplains in the team, and a real variety of needs. And I think it was encouraging that for many, some would come in sometimes even saying that they felt desperate, maybe that they just couldn't go on, but actually with relatively straightforward interventions, maybe treating a chest infection or helping with difficult pain, you could manage to get things manageable for them, so that they could get home and get to a significant birthday or a family wedding. And it was Cicely Saunders who really started the hospice movement, and it was to help people live until they die. So there is a huge amount that we can do in palliative care.
Yes, I lived in St Christopher's Hospice for a while.
I remember you saying
and
that.
I knew Cicely Saunders. I used to have lunch with her. And, so I could see the tremendous spirit alive in the hospice and alive in that care. Absolutely wonderful.
Well, she had a huge vision, I suppose. I think she was initially a nurse and then trained as a doctor and then as a social worker, or one of the way around. And I think she realised this whole holistic way of looking after patients that was so important. It wasn't just enough to give them morphine, although that was really important. It was the whole way of looking after people, and it was that model of care that she has left for the palliative care community, and really the UK has led that across the world, and that's really been her legacy, and St Christopher's.
I was particularly impressed by the way she spoke to the the folk who were in the hospice and the way she engaged with their families, you know.
Absolutely, and looking after families is hugely important, and having time, and for the nurses to have time to spend with families, and to explore some of the difficult feelings that arise when someone is facing death. So almost preparing people for bereavement and then supporting them afterwards. And some hospices and palliative care units have very well developed bereavement support, and that's very important in looking after families, helping them to process that grief.
So for you, in many ways, it was a very consoling sort of profession.
Yes, I had enjoyed acute medicine very much, but I think to have the time to spend with people and the chance to really talk about the things that mattered was a hugely rewarding part of medicine. Yeah, thank you.
But you moved on then a few years ago and went into research. Would you like to tell us something about that?
Yes, I changed for a number of reasons, to work not clinically, not on the wards, but for a small think tank who were looking into difficult ethical issues in medicine and bioethics and generally. And it was, I think, a really important time of training. I had already done a master's in medical ethics and law, but this really helped me think through, having come from practice, I guess, some of the really difficult issues that we struggle with, and there are in medicine. There are many things we can do, but ought we to do them, and should we do them for different patients at different times? And it gave me the chance to learn from really helpful seniors and people who had a great deal of experience, and also to grapple with some of these difficult issues. They're not always easy, but it was a real opportunity to think that through.
Yeah, so where did your research lead you to?
I think it gave me some time to think about particularly end-of-life issues, and the fact that the euthanasia or assisted suicide is a huge issue for our generation. In some ways it's been a topic for thousands of years, and Hippocrates clearly stated that we should not, as physicians, enter into taking life. So it's not a new issue, but I think the fact that there has been really a way for medicine to prolong life and support life in different ways, but also with a significantly ageing population, and difficult ethical issues over, for example, resuscitating patients, over the Liverpool care pathway. There have been a number of quite high-level issues in politics over the last 10 years or so, and I think I realised that for me it was really important for me to contribute or to be part of the debate against assisted dying, and to bring some of my clinical experience and some of my medical ethics to the political world, in a sense.
So and what would you say is the great concerns of, if you like, the palliative care community, medics involved in palliative care in Scotland at the present moment?
Well, they're very clear, actually. So there is a bill in the Scottish Parliament. It's not been brought by the government, it's been brought by an MSP whose name is Liam MacArthur. He's the MSP for Orkney and a Liberal Democrat. And he has lodged a bill which is to introduce assisted suicide for those who are terminally ill and who wish it. So they have to be competent or have capacity to make the decision, and they have to be able to take the medicine themselves, and they have to be terminally ill. We're awaiting the detail of that bill, so we know the principles of the bill, but we expect the detail relatively soon. He said in maybe perhaps a matter of weeks. And the palliative care community is is hugely concerned about this development. We understand that it's intended in a compassionate way, but actually when you look at polling of palliative care doctors, so specialist palliative care doctors in Scotland, 95% of them would not prescribe lethal drugs. So perhaps it helps just to maybe drill down on the definitions. So the bill is describing assisted dying, so it's the terminology used is assisted dying, and that is what we traditionally would have understood as assisted suicide. So when the patient takes the medicine themselves but the doctor prescribes the medicine, and that's different from euthanasia, where the doctor both prescribes the lethal drugs but also administers that medication, and that's usually a lethal injection. And both are very different from palliative care, when we as clinicians would give medicines to relieve distress or to help pain or to help agitation, for example, when people are dying, but we would never do anything to hasten death. We wouldn't do anything to prolong death, but also not to hasten it. So this is a very new development that the Scottish Parliament is proposing. And palliative care doctors are very clear in that they won't take part. So 95% said they wouldn't take part. But actually, interestingly, 40% said that they would resign if their hospice or hospital undertook it. And 20% of those in Scotland said they wouldn't, of trainees wouldn't embark on a career in Scotland because of it. So actually, there's quite a lot of strong feeling that as palliative care clinicians, that's not what we want to do. So it's very important, and those are for a number of reasons. We're really concerned because some patients are vulnerable and they don't necessarily understand the difference between assisted dying and palliative care. Perhaps not everyone would understand the terminology, and I guess one of my concerns is that the terminology is almost deliberately vague so that people are given that assurance that they are receiving palliative care. And we're also really concerned that people change their minds, and that people might be pressurised into taking a decision to take their own life because they feel obliged to. So lots of difficult concerns.
And what sort of groups of persons in Scotland are particularly agitated about the possibility of assisted suicide?
Well, I think a number of different groups. I think particularly clinicians who have experience of looking after patients who are dying. So GPs, cancer doctors, those doctors who look after elderly patients are concerned. But also there are folk who are concerned for elderly relatives, people perhaps who have family members with learning disability, because it's what we've seen in other countries is that although it initially comes in as a right for those who are terminally ill, it's often challenged in the courts, because as a healthcare right, then we should all have access to that. And if it's for patients who are suffering and for those who have choice, why should it just be limited to those who are terminally ill? So Canada is a very clear example of that. So it was introduced in 2015-16 for those who are terminally ill, but it was almost immediately challenged by an elderly lady who had very difficult chronic pain, and she argued that she was suffering more than somebody who was terminally ill. And so the law changed in Canada to allow for patients who have a chronic illness and who are able to make the decision. But actually what's happened even further from that is that there's a parity or an equality between chronic physical illness and chronic psychiatric or mental illness. And so there has been a move and actually been accepted to introduce euthanasia for those who have chronic psychiatric illness. So But that has actually been met with real concerns from all across Canada and from the world, actually. And so that's been paused until 2027 because clinicians are very concerned about patients, for example, with chronic schizophrenia, who may have recurrent suicidal ideation and ask for this, or chronically depressed and ask for this. Traditionally, the role of the doctor is always to counsel towards life and to encourage somebody of their value and their worth. And so to have some clinicians at one end of the hospital saying, actually, why not, and even offering this, and then others who are encouraging perhaps younger people with impulsive suicidal thoughts to not take their own lives. There's a real dichotomy of that. So huge concerns from lots of different aspects of society.
And then, of course, it's assisted suicide has been introduced to other countries in Europe. Would you like to say something about the experience there?
Yes, and I think what's helpful is they've been in place for some time. So particularly in Belgium and the Netherlands, initially, again, it was introduced as what's described as a tight or a narrow bill, but it's been extended. So, for example, it's been extended already to psychiatric euthanasia. So patients, for example, with anorexia or chronic psychiatric illness have been euthanized in the Benelux countries. And also patients with dementia, which is hugely concerning because they have given consent before they lack capacity, and then when they lack capacity, then they are euthanized with consent of family and doctor. And there was a particularly difficult case when a lady who had originally given consent when she had capacity and then lost consent, but had asked for euthanasia when she was more poorly, and then she was euthanized but had to be restrained to be euthanized, and the Dutch courts found in the favour of the doctor because that is the position of Dutch law. So you can see these very distressing and difficult situations arise that are incredibly difficult for us as a society, particularly with the rise of dementia and of particularly elderly and frail individuals.
The prospect of this bill, I mean, members of the Scottish Parliament are being invited to make a very, very fundamental decision about the direction in which we go. And it's a choice. What would you be saying to members of the Scottish Parliament at the present moment?
I think you're absolutely right. I think I heard one MSP say that it's just another wee tool in the palliative care toolkit, and it's anything but. This is a seismic shift for all of medicine, and if you look at a general hospital, a quarter of all patients who are admitted today to the big hospitals across Scotland are in the last year of life. So this doesn't just affect exceptional cases. This affects all of us, all of medicine, and all of us as a society. And it's hugely important that we as clinicians are not able to take life. It's state-sanctioned, medicalised killing is hugely over the line, the Rubicon for safe practice. And we must not legislate to allow doctors to be able to do that. So I would really encourage MSPs to think carefully about this. I'm really impressed actually by many MSPs who are thinking through this as a difficult issue. Absolutely, we need to take on board that there are families and individuals who are distressed. Absolutely. But the real issue for Scotland is that we don't have the right care for the right patients. And although palliative care is wonderful when it works and when patients can access it, there are too many patients who are not getting the right palliative care that they need. And I would so urge the MSPs to think in terms of supporting and backing palliative care rather than supporting assisted suicide, because patients are not making an informed choice. It's so important about whether someone has capacity to make a decision. It's whether they are informed and have all the information that they need. And so many patients do not get the care they need. There's just not enough care, particularly out of hours. So often 9 to 5 care can be excellent, but out of hours, patients do not get specialist care that they need, and they are admitted to general hospitals and the acute services, and they don't get what they need.
So, I mean, were this legislation to be passed, the impact on the whole culture of medicine would be absolutely immense. What would you be saying to medics and GPs in Scotland at the present moment?
I would say that please be informed about what's happening, that this is a significant and important piece of legislation that is coming through the Scottish Parliament, and MSPs are genuinely asking for information about that from clinicians, from doctors and nurses and others who are involved in healthcare, and that you have a voice in this debate, and it's an important voice because you have experience of looking after vulnerable patients and helping people think through difficult decisions. So please be part of that debate and contribute. The main ways to do it, you can write to your MSP. Everyone has 8 MSPs, your constituency MSP and 7 regional MSPs, and you can write to them all. But also, I think on this issue, it's really helpful to talk to people face to face, and I've really enjoyed and valued that. Most MSPs have some time in their communities, their constituency, that they do meet constituents face to face, and they would really appreciate speaking to a local consultant or nurse specialist or Macmillan nurse about this topic, because it is genuinely difficult. None of us wants to see patients suffering at the end of life, and we are doing all we can to not have that. But it's really helpful for MSPs to understand the difficulties in estimating prognosis, in estimating capacity, in understanding the problems of delivering a service in the NHS, all these practical difficulties of looking after, being a carer of somebody with a life-limiting illness, and all these things are hugely important. So I would really encourage you to go and speak to them face to face and just explain your concerns. You don't need to be an expert in the law, but just explain the kind of patients that you look after, and we'd be delighted to help if we can.
Thank you. And what would you wanting to be saying to people facing a terminal illness at the present moment?
I think that it is a hard time, I think, for patients who are facing a terminal illness, and our hearts go out to folk who are distressed, and there are good services available, but not everyone has access to them. And I would really encourage them to, if they can, engage with the palliative care services. I would really encourage them not to be anxious about doing that. I think some people were maybe reluctant because it's not easy to talk about death or dying. But I would really encourage people as early in their illness as they can to speak to somebody in a hospice or the Macmillan nurse, to gain their trust, because they are really keen to help you in whatever way they can. And then when perhaps things are a little further along the line, then you have a relationship with that person. I think we need to do, I think what is important for us as a society is to listen to families and individuals who are telling us that they're not getting the care that they need. And we need to listen to you who are telling us that. And I think we need to get it better for you. And I completely understand that there needs to be a push for the right care for the right people at the right time. And I'm really grateful actually for Liam MacArthur bringing this bill, because it puts palliative care firmly in the Scottish Parliament's agenda. And I think it makes us all think and talk about how best to look after patients who are at the end of life. So I so ask that you would bear with us, and even if things are not perfect, that you would be able to engage with the services that are there and tell us how we can do better, because we need you to do that too.
What would you be saying to the general public in Scotland?
I would say two things. I would say, please do think again about this topic, because I completely understand that our natural reaction to hearing about anyone suffering at the end of life is to say, is there nothing else we can do? And as palliative care clinicians, that's exactly what we wanted to do. We were in the night, trying to make people's pain better. That I would just strongly counsel that assisted suicide is not the answer. And if they do anything, please look at what's happening in Canada, because Canada has a liberal democracy, it has high standard of healthcare, and it has been a truly terrible situation there. The numbers are high, patients are being counselled to have assisted suicide when they may not have considered that.
So Gillian, thank you for sharing with us your passionate interest in care of individual persons at very difficult moments in their life, and helping them to come to the end of their life in a way that brings some consolation to them and consolation to their families. And this whole beautiful way of caring needs to be cherished, needs to be developed. Would you like just finally to say a few words about the organisation that you're working with at the present moment?
Thank you. Yes. So I changed. I'm not working as a clinician just now. I work for the organisation Care Not Killing, but particularly as director of their campaign for healthcare professionals. So we've called that Our Duty of Care, and I am keen to give a voice to healthcare professionals across medicine who are concerned about this issue. It's not easy sometimes to express your opinion, but as a campaign, we are giving a collective voice to those who are extremely concerned about the change in the role of the doctor and allowing assisted suicide in Scotland. So we're campaigning across the UK and the British Isles for to maintain palliative care and to oppose assisted suicide.
Thank you very much indeed, Gillian. Thank you.
Thank you for having me. Thank you.